hours, so I'll
We
just
totally understand. Thank you. Thank you for taking your time for us.
of course. So it's gonna be a little bit challenging trying to summarize everything in around 15 minutes, but I'll do my best, and then I'll guide you through other resources that you can use so you can get more information about that. Because if you want to discuss every detail, it would take 5-6 hours.
Sure, I know we understand time is not on our side this time, so we're just gonna try our best, and then so we'll just
Awesome,
start in the next 3 minutes. Yeah, next 2 minutes, I guess.
perfect. Yeah, awesome. Let me know when you want to start.
We're just gonna give it 2 more minutes.
Awesome.
So since we are on a very tight schedule, I think we shouldn't delay anymore. I'll start right away. So a very good evening to all of you. Welcome to our Career Pathway panel discussion hosted by the Global Surge Network. Today, we have an amazing lineup of renowned doctors ready to provide you guidance in choosing the best career pathway for you. In the next 2 hours, we'll be discussing about USMLE, UK PLAB, and next pathways in detail and answer any queries that you may have. I'm Zishan Mohammed, Regional Head here at GSN, and I'll be your moderator for this session. And with me is Divya Randhawa, Regional Assist. So without any further delays, let us begin with our very first panel discussion on USMLE. Today, we are very honored to have with us Dr. Malke Assad as our guest speaker for this panel discussion on USMLE. Now, allow me to introduce today's speaker. Dr. Malke Assad is a plastic surgery resident at the University of Pittsburgh. He graduated from Aleppo Medical School in Syria and pursued 1 year of research at the Mayo Clinic in Rochester, Minnesota, before joining the world-renowned MD Anderson Cancer Center. His research interest is reconstructive microsurgery and surgical education. We are more than honored to have you, Dr. Assad, guide us through the USMLE career pathway today.
I'm very excited to be here. Thank you for having me.
Yes, just the last 10 minutes of this webinar will be dedicated to a Q&A session where Dr. Assad will be addressing the questions the participants had put up during the registration. So before we begin, let me read down some house rules to ensure this webinar goes smoothly. We will be muting everyone, and we highly suggest the participants turn on their cameras throughout the session. This webinar is being recorded and streamed live on our GSN YouTube page. So without further ado, let's dive into the session. Over to you, Doctor.
First, thank you so much for having me. It's a pleasure to be here. And it's always a pleasure to guide future applicants through this residency journey, through this arduous journey, because you'll find for people who start preparing for the USMLE exams, there is so much misconception, so much wrong ideas about the pathway. So I'm very happy to tell the truth about what's happening here and how people can get in. So the first thing that I want to try to summarize the journey into blocks and the aspects that can help you match into whatever residency you want to do. The first thing that you need to think about when you're preparing for the USMLE exams, for the USMLE journey, US residency journey, is the exams. So I see so many people worry a lot about research and about volunteering, and when I ask them, so what's your step one score? Oh, I didn't do it. So how did you start preparing? No, I haven't started preparing. I prefer to have people start thinking about one step at a time. And the first step, in my opinion, is the USMLE exams. So in order to apply for residency in the United States as an international medical graduate, you need multiple things. You have to have certain things, and other things could be an addition to your CV to supplement your CV. So the first thing that you must have to apply for residency in the United States is the ECFMG certificate. And in order to get this certificate, you need step 1, step 2 CK, OET exams, and one of the pathways. So let's start one at a time. The step 1. Step 1 used to be one of the most important factors in deciding which applicants would be chosen for certain residency, because they filter the applications by the step 1 score. So if you have a good score, you would be more likely to receive an interview. And if you don't have a good step one score, you're out, you're filtered. However, recently the step one became pass fail, or actually recently they decided to make it pass fail in January of next year, 2022. Step one will not be reported as score anymore. So for those who are just thinking about applying or still in the process of going to the US, the step one would be something they don't need to worry much about. They just need to pass. That means you have to pass it from the first time. If you fail, it will be a very bad thing on your CV, but try to pass it from the first time, but there will be no score. Previously, it used to be the main factor. Now, there is no score. It's just pass fail. So step one score is gone. You just need to pass. What does step one cover? Step one covers anatomy, physiology, biochemistry, histology, biology, pharmacology, and pathology. The main subjects you study in the first 2 or 3 years of your medical school. So these are the topics discussed in step one. However, misconception is that step one is solely basic science. That's not true. Most of the cases that you will be asked about in the exam are clinical cases. So they tell you a 50-year-old patient present with symptoms of chest pain radiating to the arms, or giving you symptoms of myocardial infarction, and then they ask you about the pathophysiology of the disease, or a medication, or mechanism of action for the first line of treatment. So they try to combine both clinical and basic science knowledge. So that's step one. Now, for applicants who are just thinking about this, you just need to pass. Next step is step two. I prefer to study step one before step two because it gives you the base knowledge so you can build on with the step two. Step two is more clinical. So it's next step in management. What diagnosis should you order? More of a 4 or 5 year subject if you're a 6 year medical school. So it covers the internal medicine, surgery, pediatrics, OBGYN, and psychiatry, biostat. So these are the topics discussed in step two. I assume with the step one being pass fail, the tension or the stress would go towards step two score. So you previously step two score is important, but it's not that important. It's not as step one. Now step two is going to be more important. And people might wonder why step one was that important. Clinical should be more important because studies have shown that step one score correlates more with the performance of passing boards and stuff. So step one used to be a better predictor of things. That's why they used to use it. But now they took it out. So I assume the stress would be towards step two score. The step scores, they are different than your school exam, because in your school exam, if you have 100 questions and you answer 90, you get 90%. Or each question has a certain score, and if you get it, you get the score. However, in the step exam, it's more of they compare your score compared to other applicants and who are applying with you, and depending on your percentile or how you compare to other applicants in the same pool, you would get your score. So it's calculated in a very weird way. But usually 250 and above for step two would be considered a good score. That doesn't mean if you get below 250, you will not match. You'd still have a chance, but it's the lower the score, the lower your chances. Some people even match with barely passing. Why? Because they have other stuff. So one of the main things to look at when you're doing your step exams is to kind of choose good study materials. And I'm not going to go into details of the study materials because that's a whole extensive topic by itself. But I built a blog, and we'll talk about that at the end, that you can go and check for the best study resources for step one and step two. So step two, try to get a good score because now the score is important, more important than before. 250s and above. That doesn't mean that if you score lower, you're not going to match, but try to do the higher the better. But again, don't spend significant amount of time because the other factors of the application matter. The OET exam is the third thing that you need in order to apply for an ECFMG certificate. And the OET is an English test. It's not hard. You just need to prepare for it. And if you study for step one, step two, you speak English well, I don't think you'd have a problem with that. The score does not matter in that. You just need to pass it. And if you do multiple times, it doesn't matter too much. However, on the other hand, for the step exams, if you pass it, you can't repeat it. And if you fail, it shows that you failed. So it's very important that you don't fail, because if you fail, it would be a very negative thing on your CV, a red flag on your CV. So try to pass it from first time. So after step one, step two, OET, you need to apply for a ECFMG certificate. Previously, they used to have something called step two CS, which is a clinical skill exam. So CS stands for clinical skills. And through this exam, you go and talk to patients, examine them. It's more of a testing your clinical skill knowledge, not paper, like not question and answer, more of a meeting patients, patient interactions. However, with COVID, that was canceled, and they started having something called the pathways. So pathways for the CS for the ECFMG certificate, there are 6 pathways. 2 of them, if your school does a certain form of accreditation, if your school is among certain schools they have on the website, so you can check that. I have a video about that. You can check, and they have the list of these schools. But most schools outside Europe are not in these schools. So mostly European schools. There are some other schools. So you make sure to check out that list and see if your school belongs to this list. If not, there are other ways you can get the certificate. First one is if you practice in your country. So if you finish school and you get the license to practice in your country, that would be sufficient. Second one would be if you do certain type of testing in your school, and that would be considered as enough for your clinical skills. That would be enough. And there is the last one, which is pathway 6, is you go to certain doctors in your country or anywhere in the world and have them testify that you did certain encounters and something similar to the CS exam, and you were able to do that. So they need to sign up with the ECFMG and kind of do certain process for that, and they should not be compensated for that. So this is the 6th pathway. So if you satisfy any of these pathways, you'd be allowed to get this ECFMG certificate. However, and I think this is a mistake that most IMGs make, they get their ECFMG certificate, they change their Facebook status, LinkedIn status, I'm ECFMG certified, they have a party, and they apply to the match, and they don't match. The reason is this is not enough. Scores ECFMG certificate is not enough to match. There are so many other factors. That doesn't mean you won't match. Some people might, but your chances are not as high as if you did something else. What do I mean by that? So there are other factors in your application. So ECFMG certificate is required, is a must to apply. You can't match without the certificate. You can apply, but you need to be certified by the time you match. But the other factors increase now your chances of matching, like US clinical experience. Electives are better than observerships. Electives are rotations you do during your medical school period. So if you're a medical student doing US clinical experience, like rotations in a hospital, and you got the definition of an elective, that would be the best. Why? Because you would do the tasks that a US medical student would do. Exactly the same. So that's the difference between elective and the other thing that most IMGs do are observerships. Observerships are hands-off clinical rotation. So you don't do much, you just observe, from the term observership. So you're just observing, so you won't be able to examine patients, talk to patients, enter the medical records. So you would imagine why these would not be as valuable as electives, because you won't have hands-on experience. There is something called hands-on externship or observerships after people graduate, but these are not usually very helpful. Why? Because they are not done in hospitals that have residency programs. You need a place where they have a residency program so you can interact with patients, build connections through this training, and increase your chance of matching. Because connections are extremely important. I'm going to cover that more when I talk about research. But connections, people need to know you. They won't just trust somebody from the middle of nowhere and assume that they have good education. So having US clinical experience, if you're still in your early years of school, try to start planning that. And I have a detailed video on how to find US clinical experience, because this is one of the key factors to proving your clinical skills. So now we covered US clinical experience. Let's move on to research. Research, another important factor that you can use to increase your chances of matching. And the good thing about research is that you don't have to be a medical student. It doesn't matter. You could be a graduate, medical student, both work. You would get the same exposure. Because once it comes to patients, things become more complicated. But if it's research, it's fine. And research allows you to spend more time with US physicians, which means more connections, better connections. So that's why having research increases your chances of having connection in the US and increases your chance of getting a good letter of recommendation, which is the third thing I want to talk about. So letters of recommendation are extremely important in proving that you got the checkbox from a US physician. But not any US physician is valuable to write an LOR. If you get people think, oh, I have a letter of recommendation from Dr. XXX and they told me their name and last name, and assuming they are a Nobel laureate, that everyone would know them. Nobody knows these people. People in private clinics and they're outside the academic hospitals. Nobody knows these people, and nobody would care too much about their opinion because they're not within the structure of a residency, structure of a US academic hospital. So try when you get your LORs, your letters of recommendation, to get them from someone who is known within the field, who works in an academic hospital, that people would trust their opinion. That's why you're getting their opinion. That's why you're not asking your dad for their opinion. You need somebody who actually knows the system, knows what a good resident would look like, and they would say about you that you would be a good resident. So that's why US clinical experience in an academic hospital uh, and research in an academic hospital would help you. The timing of research varies. Sometimes people need a year, sometimes people need 6 months, sometimes people need 3 or 4 years. I did 3 years of research, especially for competitive specialties like plastic surgery. You need to spend longer time in research. And for me, I spent 1 year at the Mayo Clinic, the #1 hospital in the US, and 1 year at MD Anderson Cancer Center, which is the #1 cancer center in the world. So I interacted with people who are known within the field, and when they wrote me LORs as a recommendation, everyone recognized their name. So this is what you should be looking for. If you want an easy path, that's fine. Some people match in the small community hospitals, and it's still, you get US training. But if you want to do something different, be in a good place where you not only get good clinical training, but be in a place to make a difference in the field, you need to do other aspects. So now we're done with US clinical experience, research, you have your LORs, now you're ready to apply for the match. You need your personal statement, and I help applicants with that, because personal statement is another very important document that you need to have, and it doesn't cost much money. So you need to work on it, have somebody who's experienced help you with that, and that's it. It's not like you have to come to the US, spend money to live and stuff. You can do it from anywhere, and it's an important document to tell your story, why you are you. Apply, you get interviews, you apply in September, you get the interviews in now around this time, October, November, you interview, and then you submit your rank list in February, you get your results in March that you matched, and you start residency in June. So this is the journey that from A to Z. We can share the slides now that I shared with you for a few minutes, and then we can take questions.
Awesome. The host has disabled the share screening. Can you please allow that? Just give us a moment, sir. Got it.
So to help applicants with the residency application process, I started the website, the Match Guide, to help other applicants from falling to so many misconceptions about the match. So for people to know more, I started helping people with the personal statements, the interview process, advising like this on how to get residency, what do I need to do? Because I believe every applicant is different. There is no one cookie cutter for everyone to do the same. Every applicant is different, and the plan and the guidance should be individualized. So if you can advance the slide, please. So that's the website. If you go to themadguy.com, you would see these things at the top. The services has all the services we provide. We have the courses. So I built 2 courses to educate medical students about research, and we'll talk about that now. The blog, fully free for all the applicants. You can check the blog so you can learn about what to study for step 1, step 2, how to prepare for interviews, all these details. You can check our reviews for the services. And if you want to have any questions, you can click on the contact us. Please advance.
Sorry, one second.
So this is the research course. The research course is very helpful for students who are now in med school or just starting their research position to know research from A to Z. Because I'm sure, like me, you didn't have much exposure to research in your medical school. So this course is very helpful for you, so you can know about research and practice with articles, exercises, quizzes. The course is 100% refund if you don't like it. So if you buy it and you don't like it, you can let us know and we can give you a full refund. And advance, please. And we have also a course about medical statistics. So I feel that statistics is another area that medical students are not very strong in. And this course gives you from, again, A to not Z, because statistics doesn't have a Z. It's like very complicated. So maybe A to L or M, something like that. It's in the middle of the statistics. It starts with the descriptive statistic, going chi-square, Fisher, ANOVA, then going into regression analysis, but not more. But all the details of what the course covers also on the website. If you go to courses and you get drop-down list and check the details of that. And this course is also 100% refund if you don't like it. And you can check the reviews for students who already took part in these two courses. Advance, please. And finally, my YouTube channel. This is the platform that most students use. I have almost now 19,000 subscribers. It has step 1 videos, US clinical experience, research, applying to the match, and every aspect that you want to learn. If you have also any suggestions for future videos, let me know and we can add that. And now we can take questions. Of this final slide, I probably missed one. If you can share that, please.
Sorry, which one, sir?
There is the final one.
Oh, okay.
Probably the one after the YouTube.
One second.
Probably missed that one.
One second, sir.
And I also have Instagram at Malki Assad. I share useful posts for students. Oh, this is about the Instagram. So just search in Instagram at Malki Assad and you'll find, sometimes I do live webinars, like live Instagram. I share some advice, some stuff on there. There is these highlights that you can also use to learn more about the process. And now we can take questions.
All right. Thank you so much, sir. As I said, time is not on our side, but thank you for summing up such a vast topic in such a short time. So now we'll be moving on to my assist, who is going to be asking you a few questions that we already took during the registration. And whenever it's time for you to go, you can just let us know, because we have a lot of questions for you, but still, you can just let us know. Over to you, Divya.
Thank you, sir. As Zishan said, it was a brief yet a very crisp session. I'm sure everybody learned a lot from you. And without wasting more time, I'll just start with the questions. So the first question is how to prepare for getting into a surgical branch in the US, specifically for surgery.
So everything that I talked about, that starting from the exams, research, US clinical experience, volunteering, good LORs, and personal statement apply for surgery. However, you just need to show your interest in surgery through doing these US clinical experiences, these type of research in surgery. And if you do that, you would be able to have increased chances of matching into residency in the US. Surgery, however, there is like one single difference, is that most IMGs match into prelim positions, which are 1-year spots. And afterwards, if you prove that you're good, you can match it to categorical. But some applicants actually make it to categorical directly. So both work.
Right. So the second question is the importance of research during the match and what can be done if we don't have sufficient research in our CV.
Research is very important for two folds, not only the publications and the presentations, which are really nice to have on your CV, but also the connections that can get you good LORs and people to call for you when the time comes on, when they are interested in you, they call your mentors and they give good feedback about you. So if you don't have research, start doing research. That's the only advice I have for you. Start looking for research positions, take this research course, learn about research, start doing it in your school, but it's also important to do it in the US.
Right. Okay. So from 2022, since USMLE is going to become pass or fail for step 1, how will that impact IMGs interested in surgery and applying for electives?
it's not gonna affect them. That's the thing that I people ask over and over again. It's gonna change, so there is nothing for you to do. Don't worry too much. Just focus on the other aspects. If anyone tells you there were 5 factors in choosing residence and now there are 4, so it would shift to these factors: step 2 score, research, US clinical experience, and personal knowledge of the applicant.
Used to prefer doing step 1 before electives, so that the score is highlighted in their CV.
Yes, I prefer, and that's only I prefer. Sometimes you have to. You don't have an option. They ask you for your step 1 before you apply for electives. So yes, I recommend you do that.
Right. Okay. Do observerships count for applying to surgical residencies?
Everything helps. It's better than sitting at home and watching TV. However, you have to think, is this time can be used for something more useful? If you're gonna, I see applicants doing literally a year of observership. Like what? That's not helpful, because it's not. What are you gonna get from a year of observership? You're just observing. You're doing nothing, especially in surgery. You're not You're not doing operation. They won't allow you to scrub in. So maybe a month or 2, maximum 3 of observership. But think how you can use that time to better help you, like in research.
Right. Will Indians be able to apply for the match after 2024?
Will who?
Indians or IMGs in general?
Yeah. Everyone will be able to apply. Why? The school changes. These schools will find a way to get themselves accredited. So don't worry too much. If you're in that time period, that transition, try to submit your Form 186 before 2024. And even if you do your exams afterwards, that would be fine.
Okay. What can IMGs do to increase their chances of matching into surgery? For cardiothoracic and neurosurgical residency programs, what pathway would you recommend? Fast track, integrated, or general and then specialization?
You should apply to both. I think you should definitely apply to both, because the integrated alone is tough. And I myself applied for general surgery as well. And then if you manage to integrate it, perfect. If not, you can do it the other way. How you can improve your chances? Everything. And again, everything I talked about, try to optimize that. Scores, research, and US clinical experience.
Right. And last question, does home country research count while applying for surgery?
It helps a little bit, but it doesn't help significantly. In my opinion, try to do as much research here in the US. If you're a student there and you have you have a lot of free time, yes, do it. That helps because it gets you more publications, but you should do research here in the US as well.
Right. Okay, I think we're right on time. And thank you so much, sir, for enlightening us on the USMLE journey and also taking up the questions. If the participants have any more questions, I'm sure they can contact you directly, as you've already mentioned your Instagram account.
Yes,
Thank you
exactly.
once again for joining us despite your tight schedule.
My pleasure. My pleasure. Thank you for having me.
Thank you, sir.
Bye-bye.
Thank you, sir. So we'll be moving on to our next panel discussion, which is UK PLAB. So I'll be handing it over to Saloni now. Thank you.
Yes, sir. Good evening to one and all. I am Dr. Saloni Bankapalli, the regional head at GSN, and I welcome you all to Career Pathway panel discussion for PLAB. The panel has Dr. Raza, regional head East, and Dr. Mansi Manasvi, and Dr. Dia, regional SS. Now, let me introduce you to our keynote speaker, Dr. Shitanshu Kalani, sir. We are very honored to have you on board, sir. Sir is currently working as a radiology resident in Nottingham University Hospitals. He also actively interacts with medical students on social platforms, providing guidance for the PLAB pathway. The agenda also consists of a Q&A session at the end. So I kindly request all the participants to switch on their cameras throughout the session. Over to you, sir.
Thank you very much. Thank you so much for inviting me here. So I've already been introduced and there's nothing much to say. Probably the only achievement in my life is getting into radiology training in UK. So I just keep it short and I'll be taking this talk forward with the help of a presentation I've made. So either I can share my screen, or if you have got it open, then whatever is more convenient for you.
So I think you can do it.
Okay, so let me just share my screen. Okay, so can you see my screen now?
Yes, I can see.
All right, great. So because we are short of time, we are just going to talk more about the PLAB pathway itself, which is the ideal pathway for post-MBBS students. So just a bit about myself again. I completed MBBS in 2018, gave my PLAB 1 and PLAB 2 in the same year, got my GMC registration in the same year again, and I landed my first job in January 19. And currently, I'm working as a first-year radiology resident, which I got into in this year. So just a mention of the few basic things, which is how the healthcare system is, because it just sets the base for everything we'll talk about today. So first of all, healthcare is free in UK, which is provided by National Health Service called NHS. And there are a few private hospitals in UK, but majority of population will access the NHS services. And the more important thing is you can only do your residency in the NHS hospitals. You cannot do it in a private hospital. You can do a job, but not a residency. And the other thing is there's no such thing as doing a residency from a college in UK. All the hospitals are university hospitals or maybe district general hospitals and so on. So it's all done in a hospital, and it is basically like you're doing a job. So you cannot actually come and pay for a residency. So three main pathways for GMC registration. GMC is General Medical Council. So that is the licensing body, like we have Medical Council of India. The main pathway, PLAB pathway, which most of you have heard about. And this is the best pathway for someone who is post MBBS, who've just done their MBBS or maybe waiting to apply for a postgraduate seat somewhere else in their home country. The other pathways, they are best for someone who has completed post-graduation or they are in post-graduation training back home. So we're not going to touch much about this thing because we are short of time. And the third pathway, which they have recently introduced, is the USMLE pathway. So in short, just to summarize, if someone has passed their USMLE before March 2020, they can skip all the exams, PLAB or MRCP, MRCS, etc., and they can straight away apply for GMC registration. So this is a new thing, but all you get is GMC registration, nothing more than that. So this is the whole pathway. I've just summarized the whole pathway in one slide along with the expenditure. So as you can see, your journey will start with your English test. Everyone has to appear for the English test. Either you can give IELTS or OET, both are accepted. It doesn't make a difference. The next step is PLAB 1, followed by PLAB 2. And obviously the other expenses which I have mentioned here. So the take home point is the total expenditure here is about £5,000, which is roughly equivalent to 5 lakh Indian rupees. £1 is about 100 rupees. So that's the approximate cost. Obviously it can go up and down depending on your living expenses while you are here. Now, I've just put this extra slide for people who have completed MBBS or going to complete MBBS. Where to start? How do you make your timeline? So as I said in the previous slide, your journey will start with the English test. So if you're thinking about this pathway, the first thing to do is book your English test, which is OET or IELTS. They're available at various centers throughout India, and getting a date for that is not that difficult. So ideally, your aim should be to pass your English test and PLAB 1 during internship. You can appear for PLABs after completing your final year. All you need is a final year passing certificate. And PLAB 2 should be done after internship because you need to go to UK for that. PLAB 2 is only held in the UK. And if I'll be very honest with you, you can actually start working within a year of passing all these exams. So let's say you started your journey today, you appeared for your English test today. Within a year, you can actually start working in the UK, provided you pass all the exams and you get the dates. Getting a date is the biggest problem these days because of COVID, but things are improving, and I'm sure it will be back to normal soon by the end of next year. But again, this is the ideal timeline. It's not going to be the same for everyone, and it is never late. There are people who have been preparing for NEET PG or other exams since the last 2 years, have been unsuccessful. So it doesn't matter if you have a gap of 2-3 years, as long as you can explain it, it's fine. The GMC takes into consideration all of that. So it is never late. Now, what happens after GMC registration? A lot of people don't know, they don't understand what happens after PLAB because they try and compare PLAB with USMLE or NEET PG. It's different because the only thing you're getting after PLAB is GMC registration. So you're just getting a license to practice in UK. You're not actually getting into a residency. You're not even getting a job. You're just eligible to apply for a job. So even if you want to apply for a job after that, you need to appear for interviews, keep applying. And then after that, you can apply for residency. Now, UK is very different compared to US and India because there is no central exam apart from PLAB. You've given PLAB, you got your registration, but to get into a residency, every specialty has its own application and interview. So you need to apply separately for any specialty you are interested in, and you have to give the interview or the relevant exams. Okay, so usually the timeline is the applications start in November, interviews are held in January or February, and the training will start in August or September. Now, I've always feel this is probably one of the most important slides for everyone, because this is what everyone is after. Like, what is the salary? How does it compare to India? How does it compare to US? So I've just summarized it. This is salary from your first job. Okay. So average take home pay, which is after taxes and everything, is about £2,500. And just to briefly summarize it, this whole slide, you can easily save up to £1,500 in a month, which is 1.5 lakh Indian rupees as a junior doctor in UK from your first job. Now, the salary in UK depends on very much on how many nights or weekends you're working. For example, my salary as a radiology trainee has actually gone down from my first job because I was working for 2 years. So I had an increment in my second year, but now I'm back to first year of radiology training. So I'm back to the basic scale. Plus, I don't have any nights in first year. So my salary is actually about 2,500 again, despite working for 3 years in UK. So it depends a lot on how many nights, how many weekends you're working. If you're working in emergency department, if you're working in a surgical specialty, your salary will be higher. But obviously it will keep, the increment will be there. From second year, I'll have more pay. From third year, it will be even more. So that's how it's going to happen. And this salary is actually for working 48 hours a week on average. So the biggest advantage of working in UK is you're not working much. So you are working on average about 48 hours, and this is uniform for every specialty. Even an emergency doctor won't be working more than 48 hours a week on average. There might be weeks where they would be working more than 50 hours, but it will be compensated. In the next week, they won't work more than 20 hours. So you get about 8 to 9 days off in a month, which is a lot, I feel. And that is excluding your annual leaves. And you have an opportunity to earn more if you want to save some more money for a house or a car, or you want to send some back home. You can do extra shifts. We call that locum, and that is paid at about 40 to 45 pounds per hour. Okay. And as I mentioned, salary keeps increasing as you progress to next year. Coming to the training process. Now, I've already mentioned that every specialty has its own pathway, and that is why it is a very complex training structure here in UK. So if to be fair, if I start talking about each specialty, it would take at least half an hour for each specialty. So I'll briefly mention what happens here. So some training, they are called as core training specialties for like medicine, surgery, psychiatry, where you need to do 2 or 3 years of core training. After that, you need to appear for more interviews, and then you go for 4 or 5 years of specialty training. Now, specialty training is equivalent to something called DM or MCH in India. So you can say it's subspecialty training. Like you will do core training in medicine, and then you'll go on to do cardiology, respiratory, etc., etc. And some training are run-through training, which are radiology, ophthalmology. So basically all specialties other than medicine, surgery, and psychiatry, they are run-through training. That means once you get in, you don't have to appear for any more interviews. After the duration of that, after the entire duration, you'll become a consultant. So for example, I'm in radiology. Radiology is 5 years. I've already got into radiology. After 5 years, I'll be a consultant. I don't need to appear for any more interviews. And this is roughly the duration of training in different specialties. Residency is long in UK, but as I mentioned, the subspecialty training is equivalent to a DM or MCH in India. So even in India, it will take about 6 years to become a super specialist. You do MD, you do MS, and then followed by a DM or MCH, and provided you get into the program in first attempt. So again, it's going to take 7 to 8 years. So general practice is the smallest, 3 years, pathology 5 years, radiology 5 to 6 years. Most of the medical specialties are 7 years, and all other specialties are again 7 to 8 years. So roughly you will be spending about 8 to 9 years to become a consultant when you think about coming to UK. So you need to bear that in mind. And I've already mentioned each specialty has its own application. So I'm not going to go into the details of that. They all have their own marking scheme. Some of them, they will give more preference to the interview. Some of them, they will give more preference to the portfolio. The most competitive specialties are just like any other country. The most surgical specialties are competitive. Public health medicine is competitive. Some medical specialties like dermatology, cardiology, that's again uniform everywhere. Radiology is competitive as well. Less competitive specialties, peds, surprisingly, is a less competitive specialty. It's actually the least competitive specialty in UK, just because of the risk and the legal litigation in UK. Psych, GP, some medical specialties like acute medicine and emergency medicine. So I've put the slide because there were a lot of questions regarding the portfolio. So again, obviously, the point of this session is to focus more on what is more important for you. So what are the few things you can do on a portfolio? Now, this portfolio is a general portfolio. Obviously, as I said, for different specialty training applications, for your residency application, the portfolio will be separate and you can always check it online. All the specialties have their own website and they've given a clear-cut scoring pattern. So you can decide what you need to do. But this is more like a general portfolio, what you will need when you're applying for non-training jobs after your PLAB. So the basic things like audits, publications, teaching sessions, it can be like you can be a final year student or an intern and you can organize teaching sessions for first and second year students or maybe nurses. All you need is a certificate. You can organize events. You can volunteer for health camps. That's organizing an event. Passing MRCP, MRCS exams. A lot of people do that while waiting for their PLAB dates because it's getting difficult to get a PLAB date. They just start preparing for MRCP as well. And that helps as well in your portfolio. The single most important thing here in this portfolio is doing a clinical attachment in UK. It's become very popular. What people do is they come here, when they come here for PLAB 2, they'll have to wait for about a month to get their results. So during that 1 month, they will find a hospital and do an observership program. You can say it's similar to the elective program in US or elsewhere. So that shows when you actually apply for a job and you mention that you have done a clinical attachment in UK, you can say that I have seen the system, I know how the system works, so I've got some experience, and that helps your job application. And obviously any previous work experience counts as well. So as I mentioned, if you want to find out more about a particular specialty, just Google, for example, let's say you want to find about surgical training, just Google core surgical training recruitment. You can Google pediatrics recruitment and it will take you to the website. It will take you the scoring pattern as well. So you can prepare and tailor your portfolio accordingly. There's something called as person specification attached with every job advert. This can be a training post and this can be a non-training post as well. So when you're applying for a job, let's say a non-training job, there will be a person specification and they will mention what is expected from the candidates. So there will be desired criteria, there will be essential criteria. So if you have essential criteria, they will at least consider your application and call you to the interview. So again, this slide is from a question, what is the current job scenario? So as I mentioned, the biggest difficulty is getting a date these days, but it is improving. With regards to job, again, it was getting a bit difficult getting a job in the last year, but I do have friends now who have not done any clinical attachment, are just post MBBS and still they have got a job in about 2 months. So it's not taking long now. On average, it takes about 3 to 6 months to land a job. Obviously, if your portfolio is good, you might even get a job just after passing PLAB 2 without waiting for GMC registration. But the general thing is getting into a residency in UK is easier than India or US or Australia. I think it's probably the easiest place to get into a residency. If you look at the competition ratios for radiology, radiology is considered as a competitive specialty. The competition ratio is 4:1. So there were about 350 posts for radiology last year when I applied, and about 16 or 1700 applicants. So you can imagine it's nothing compared to India. It's nothing compared to US. Even in US, you need a very high score to get into radiology. So in general, getting into residency in UK, it's much easier if you just look at the competition ratios. But obviously, you're competing with the very best of people. They have been working here, prepared their portfolio over the last 2-3 years. And obviously, if you're competing with British students, British graduates, they have been preparing their portfolio since their medical school. And again, the last point here is everyone has an equal chance of getting into a residency. There was a time before 2019 when British and EU citizens were given preference. So what used to happen is, and it still happens, you've got 2 rounds of any residency. So round 1 used to be only for British and EU citizens. And then whatever seats were left over, they used to go to round 2 for which IMGs were applicable. That thing changed in October 2019. Now round 1 is open to everyone. So there is no special preference to anyone. Everyone is at an equal level. So you are given an equal chance, and you cannot say that the British person is getting any special preference. Some resources, just a quick overview. For PLAB 1, you don't really need to attend any coaching. So I've not mentioned about this. So PLAB 1 is just a test of all the clinical subjects, which means your final year subjects, medicine, surgery, OBG, peds, and ENT, Ophthal, the 3rd year subjects. They don't really test anatomy or physiology, biochemistry. There might be some clinical anatomy, which is more linked to orthopedics, and there might be some pharmacology, which comes under medicine, but it's not testing your basics. So all you need is about 4 to 6 months if you've got a very tight schedule. If you are not working, then you can even prepare for PLAB 1 in 2 to 3 months. And you don't really need to attend coaching. I don't recommend that. All you need to do is maybe 2 or 3 question banks. PLABable is the most important one because 50% of the questions in PLAB are repeated. So PLABable is just a collection of all those questions which have been tested over the last few years. The other ones are MedRevision, PLAB keys, and obviously, if you want to use a guidebook, which the best one is Oxford Handbook of Clinical Medicine. So if you're preparing for PLAB 1, I would advise you to go through at least the emergency section of Oxford Handbook. The flowcharts are really good. For PLAB 2 is a talk in itself. It will take about at least 1 hour to explain what happens, but PLAB 2 is more about your communication skills. They're not testing your knowledge. So usually it used to be 18 stations when I was giving it. Now it's 16 stations. You've got actors who are acting as a patient. You will be asked to do a consultation like you're a doctor, and there will be an examiner assessing you. There are stations where you have telephone consultation with the patient. So it's like much like what you do in the hospital. But again, it's testing your knowledge. So if I give my example, I had 18 stations during my exam. In 12 stations, I did not give a diagnosis. I said, I'm not sure what's wrong with you, but we'll find out and we'll investigate further. So it doesn't matter if you don't know. They are not testing your knowledge. They just want to see how you interact with the patient. So that's PLAB 2. Again, this is a question, frequently asked question. What are your options if you want to come back to India? So I've already mentioned that UK consultants, they are considered equivalent to DM or MCH in India because you're becoming a consultant only after completing the full length of training. You cannot quit after core training. You have to subspecialize, and only then you become a consultant. And the other thing is, because let's say a medical consultant is, there is a medical consultant in UK. So there will be, he will be a cardiologist, a respiratory pulmonologist, anything, but they will get a dual degree, which is general internal medicine plus cardiology. That's how it's going to happen. So you will always be a GIM consultant as well, along with your subspecialty. All the UK qualifications except general practice are recognized in India. So you don't need to give any exam. Straight away, you can get your registration. It's mentioned in the MCI Act. So that's fine. But the difficult thing is, in coming back to India, is you need to take into personal factors. Because as I mentioned, the residency is long. You will be spending 8 to 9 years in UK just to complete your residency. And it's not like you will complete 8 years and the next flight you'll board back to India and come back and start practicing in India. It's not how it's going to happen. You'll maybe take 8 years to become a consultant. You will spend at least 1 or 2 years as a practicing consultant in UK, and then you will decide to go back. So you're thinking about, so let's say, let's take into consideration 10 years. You're spending 10 years in UK. So it's not easy to go back to a different system after 10 years. So you'll be staying here for 10 years. And think about it practically. In 10 years, you will be starting a family. You'll have a lot of personal factors. So you need to take into account all of that. It's not easy going back after 10 years. But I do know consultants who have gone back. Obviously, there are other factors. Just a bit about the UK MLA, because PLAB won't exist after 2024 and it will be called UK MLA, something called UK Medical Licensing Assessment. You don't need to worry about it. I've seen the curriculum. From what I've seen, it's same. The test pattern is also same. You've got 2 exams. One is theory, one is practical, pretty much like PLAB 1 and PLAB 2. Curriculum for part 1 is same as PLAB. Again, they are only testing clinical subjects, and PLAB 2 and the UKMLA second part is similar to PLAB 2. So there's nothing to worry about. They're just changing the name. People do ask a lot about this. What are the cons of working in UK? And I think I've already touched on them. One is the long residency, takes about 7 to 8 years. There's no guarantee. Yes, it's easier than other countries, but again, there's no guarantee. Second biggest disadvantage, you cannot bring your parents permanently to UK. No matter if you become a citizen, if your children are citizens as well. So just what do you mean by dependents? I just want to mention that. So there's something called as dependent visa. So let's say I am working here in UK on a visa, but still, if I have a wife or if I have a girlfriend or anything, I can bring them to UK on a dependent visa. They don't need a job to come here, but parents are not included as dependents. So you cannot bring your parents to UK on a dependent visa. They have to come on a visit visa only. And they can stay in UK maximum for 6 months in 1 year. So it's not easy to keep bringing them here again and again. And the last point is low consultant salary. So when you compare the salary of a resident with us, so I think US is the benchmark for when it comes to salary, because they have the highest salaries arguably in the whole world. But when it comes to salary for a resident, I feel it's more in UK, because you, as a resident, you will be getting about £3,000 on average for working 48 hours a week, compared to a US resident who's earning about $3,300 for working maybe 60 or 70 hours a week. So as a resident, the salary is higher in UK, but as a consultant, it's quite low, because a final year resident, his salary would almost be equal to a consultant. So as a consultant, you don't get much here in UK. So that's one of the disadvantages. And many people, after becoming a consultant, they want to go out or work in the Middle East or go back to India, wherever there's a higher salary. So again, a comparison with the US, just so that it makes it clear. PLAB only gets you a job, as I've explained. You don't enter a residency, and you get a residency after USMLE. So it's different. Residency is longer in UK, but working hours are less in UK as well. And I've already mentioned consultant salaries are higher in US. What about the settlement? The settlement is one of the disadvantages, I would say, in UK, because you will get a PR, which permanent residence, which is called as indefinite leave to remain here in UK after working for 5 years, and you will get a passport after 6 years. So it's quite straightforward. So that was a brief summary, and I think we should take some questions now. Yeah, I think we are right on time for now. So shall we go through the questions?
And also about mentioning all the important updates regarding the pathway. Yes, sir. Yes, sir. So coming to the first question, how to plan and how to prepare for all the 3 exams, which is PLAB, USMLE, and NEXT. My
simple advice is don't do that. Don't keep your legs in all the boats. It's very difficult, because if you talk just about PLAB, I've mentioned PLAB is not getting you anything except a registration. So you need to work on everything to complete the whole picture. Same goes with USMLE. Your scores and everything, they're not going to form the complete picture. You need to prepare accordingly of where you're going. So the simple answer is don't do that. It's good to keep backup. Definitely, it's always good to keep backup. But let's say if you're preparing for NEET PG, you have been unsuccessful and you want to go abroad, that's fine. But choose one country and focus on that. It's about commitment to one country.
Right, sir. So the next question is it possible to come back and work in India after completion of post-graduation in UK?
Yeah, definitely. So I did mention that all the UK qualifications are recognized in India, and you can come back and work in India. I do know consultants who've been working in India, and some of them, they even work for 5 or 6 months in India, and then they come back and work for 5 or 6 months here just to keep up their registration. So it's definitely possible.
Okay. The next question is, will we be considered equivalent to an MS doctor in India after doing MRCS from the UK?
So MRCS is just an exam. Officially on paper, yes, you are considered equivalent to an MS surgeon if you have passed your MRCS exam, all the steps. Similarly, if you have passed all your MRCP exams, you're considered equivalent to a MD doctor in India. But many people just give this exam even without ever coming to UK. So on paper, yeah, you can go out and practice, but if you think about it, just passing exams doesn't make you a good doctor, right? You still need that exposure. You need to work in a hospital. There could be someone who could, was just sitting there out there in the garden, studying 10 hours a day, and maybe he'll pass the exams in 3 years. But that doesn't mean you can make him a doctor. So you still need that practical exposure. So it's not really about passing your exams. It's about how you, whether you have actually worked in a hospital, whether you have been working for 3-4 years, have you got that experience to see all kind of cases?
Okay, sir. What tips would you like to throw some light on for PLAB 2 preparation?
So PLAB 2 preparation, as I mentioned that it's about your communication skills. Okay. It doesn't require an intensive preparation. All right. The first thing is you do need to have some good hold of your English, again, with regards to communication, not literature, not vocabulary, just in the way how you talk. My tips would be practice as much as you can when you come to UK for your PLAB 2 exam. Even there are people who do not take coaching and they do pass the exam because there are Facebook groups. You can go on the Facebook groups and just find a partner who to practice. So practice with different people, take their feedback. Don't take it too personally. It doesn't matter. But watch. There are some good YouTube videos as well where they have put up videos of how UK doctors communicate with patients. So they are some good resources as well to practice. So it's all about practicing. You can even watch yourself in the mirror, pick up a station, pick up a question like this is what you're asked to do. Time yourself. That is again very important. You get only 8 minutes. So you need to do that in a timed fashion and you need to complete your consultation in 8 minutes. So practice is the key. That's what I would say.
Okay, sir. So I would like to invite Dr. Raza to take on the further questions. Dr. Raza, can you please continue?
Thank you, Dr. Saloni. Sir, most of the questions are regarding portfolio. Like how can we make a portfolio and enter into research in public health?
So public health is a very broad specialty in UK. There are two options. Either you enter public health training, which is like entering any medical or surgical training. So there is a special branch called public health medicine. It's a very competitive field, but that is for as a doctor. The second pathway is you do a master's in public health from a university in UK, but that is a non-doctor role. So you will be based more into research. Now, to be very honest, public health medicine is I would say it is a closed field for IMGs because it is a very prestigious job. You're working with Public Health England. So they prefer people who are British. I'll be very open about this. I don't know any IMG personally who's got into public health job. I'm not talking about training, but who's landed a successful public health job. I've mostly seen British faces or maybe British Indian faces in that field. But again, the pathway is, again, as I said, you've got two options. Either you enter public health training. So once you give your PLABs and everything, you need to appear for exam, MSRA, which is the exam for many specialties. You have to appear for interview, and then it is 5 years training. But obviously, if you're entering training, then at least you will get a good job because you have completed the formal training and as a doctor. Getting a job after just completing a master's in public health, it's very difficult. As I said, I haven't heard of anyone. Usually, I know people who have done masters in public health, but they have just used that degree to claim points in their residency application. They've not used it to get a job because I've seen posts on Facebook and this was their advice that they couldn't find a job. It's very difficult.
And then the next questions are, if we are doing audits, research works, and teaching experience programs in India, as well as for leadership skills, will it be counted in UK?
Yeah, definitely. It will be counted. So my event organization program, for which I claimed full points in my radiology application, they were from India. So definitely it will count in your all your jobs, all your residency applications as well. The thing in UK is whatever you provide them, they will trust you. They won't ask you for any further proof. They are not actually going to contact that organization. If you're provided a certificate, they will accept it. So it will definitely be counted. So it's a good idea to start doing that while you are in India.
Are there opportunities for female surgeons in UK?
Yeah, definitely. There are a lot of female surgeons in UK. So I talked about this before, that everyone is at the same level. I do have friends as well who have gotten into surgical training. So a lot of female friends, and it's same for everyone. It's all about interest. If you're willing to work hard on your portfolio, there's no special preference to anyone. It's all about your portfolio score, because portfolio score is straightforward. This is what you have, so you'll be marked for this. This is what you don't have, so you'll be given 0 for that. And then the interview itself. So there are a lot of female surgeons in UK. There's no, I don't see any problem with that, or any special preference given to males over females.
Can one do internship from UK if he or she hasn't done it from the home country or the country from which he or she did MBBS?
So you can do that. There is something called as foundation year training. It starts from FY1 year. So the hierarchy is FY1, FY2, then core training, and then specialty training, and then a consultant. So that's the whole hierarchy. So if you've not done an internship, you can start from an FY1 post. The problem is it's very difficult because you're competing with British medical students. So British medical students, they need to give an exam called as SJT, Situational Judgmental Test. This is an exam which is not testing anything clinical. It's like an ethical exam. And based on the score in this exam, you are ranked and given your position for FY1 in a hospital. Now, let's say someone from abroad is coming and competing with them. You have to give the same exam, SJT, and you have to compete in an exam which is going to be very different to you. We don't really focus on ethics elsewhere in different countries. Now, the other thing is you still need to give your PLABs as well. So you need to pass PLAB 1, you need to pass PLAB 2, you need to pass the English test, and on top of that, you need to pass SJT as well. So you need to pass 4 exams in 1 year to enter FY1 position. So it's very difficult, but it is possible.
Sir, how can one find opportunities to build a portfolio in India, as well as how can one go for portfolio since their first year?
So in first year, I wouldn't recommend. I think you should start building your portfolio maybe from the third or final year. All you need is one audit. Okay. So if you understand the audit process, now it's difficult to explain it because we're short of time, but I've made a video on clinical audit. So if you check my YouTube channel, just do one audit. Publication is easy because all you need to do is find a senior or maybe a resident, a PG resident in India who's doing, because all of them, they are involved in some kind of thesis or something. So just help them out with that, or maybe your consultants. Just find someone who's friendly and just tell them you are interested in pursuing this. If you don't find anyone, it's fine. Just find a very rare or interesting case, make a case report on that. And there are various journals even in India. So for a non-training job, it doesn't have to be a very reputed journal. You just start your journey slowly. Just get a small publication in a small journal. It's fine. All you need to show them is that you understand the process of this writing a case report, or you understand the process of doing an audit. So I would recommend you start doing that from third or fourth year. For teaching sessions, it's ideal you do it during internship. All you need is, again, 1 or 2 teaching sessions, which you can easily do during a whole year.
As sir, on the teaching session note itself, is Google Forms valid as an evidence for teaching experience?
Yeah, you can either create your own forms, or you can actually go on the Royal College of Physicians website. They've got forms for everything. So if you if you Google JRCPTB and write teaching feedback in Google, it will take you straight to that website. They've got preset forms, which you can get filled by the students who have attended your teaching session.
Sir, how will one manage the gap between PLAB and passing their MBBS? How can we justify it if someone has a gap?
So usually there is no problem if your gap is less than 2 years. Now, if your gap is more than 2 years, then the GMC will ask, why have you been out of clinical practice for more than 2 years? Now, there are a lot of people who have even got a GMC registration after 10 years of gap. All you need to explain, you just need to have a valid reason. You need to be honest. So you can say that you were taking a career break, which is fine. You can say that you were preparing for exams and you were unsuccessful. That is also fine. You can just show anything. If you were involved in any kind of volunteer work or anything else, maybe you were traveling, again, you can show that as well. All you need to do is be honest. They don't really mind gaps as long as you have got a valid reason. So most of the people who have got a gap after, like, let's say they've been preparing for NEET PG and they've been preparing for 2 or 3 years. So you can use that reason. Definitely, you can attach your proof as well that you were appearing for these exams. You're not successful. So now you don't want to pursue this journey again, and you want to move over to a different country. So they will accept that, and there are people who have done that.
Sir, will MRCS provide us with extra edge in working corporate hospitals in India?
Well, I don't think so really, because like, let's say if you're applying for a job in India, there is a person who's done MS general surgery and there is a person who's got MBBS and MRCS. So technically he will be equivalent to MS general surgeon, but it's up to the hospital. So as if you see it from the hospital's perspective, they know that this guy he's passed this exam, but obviously the next question will be, have you worked in the UK? So if you have not worked in the UK, then you're not going to be taken into consideration, because that's what they're looking for. They want to look at your experience. Now contrast that to someone who's done MRCS and done training in UK as well. So obviously it will be much easier, and in fact he'll get a better post compared to a MS general surgeon in India, because it's the way how things work in India, that someone has come from UK or US completing the residency there, so they'll be given a higher preference. So as I said again, MRCS is just an exam. It's about proving your skills and proving your experience as well. So it's not just about exams.
And sir, this will be much more sensitive question. How can we compare a PLAB or UK pathway as compared to NEET PG in the long run about the fruitfulness?
So the thing is, there is uncertainty in every pathway in every country. Obviously, it's not guaranteed that you will pass all your PLAB exams, even though the passing rate is 70%. There are 30% people who do fail. So the people who have failed, like my friends, they were completely hell-bent on coming to UK. So they were like, we don't care if we fail 2 or 3 times, we are coming to UK, that's our goal. So that's what you need to bear in mind. Even though you will face failures, you will have obstacles. You should only decide on moving to a country abroad. It can be US, UK, anywhere, if you are ready to face that. Okay. Now people say that uncertainty is there in India as well, but there is a difference. For if you are pursuing a journey which is outside your country, for NEET, you're not leaving your country. For NEET, you're just staying in your country. You are in your own environment. You are in your comfort zone. But when you move abroad, you're going on a different journey in a different country. So when you fail over there is a difference. You don't have that comfort zone. So there will be times, obviously, if you're not successful, you'll feel very low and you are away from your country. So that's the biggest difference you need to bear in mind and decide whether you want to pursue this journey or not. So as I mentioned before, you have to bear in mind about the commitment. You need to make a commitment to anything you're doing. That's why it's not a good idea to think about doing all 3 exams simultaneously. First of all, the exams are different, preparation is different, and the whole journey is different. So if you are planning for UK, bear in mind that you will have to spend at least 8 to 9 years. You might fail at some point. You might be successful in the first attempt as well, but not everyone is. But the difference is you're not in your home country. You are in a different country altogether.
There's been a lot of questions, I guess, and you have all answered it very well for us, the beginners. And sir, there's just one more question. Last question. Can we take it up?
Yeah, sure.
Sir, how can one apply for clinical attachment from India itself? And is it possible?
Yeah, definitely. So when you're planning your journey when you're planning your visa and everything for your PLAB 2, so as soon as you pass your PLAB 1, ideally you should start applying for clinical attachments as well. Simplest way is find a city where you want to, where you're going. Let's say you're coming to Manchester for your PLAB 2. So it will be easier to commute within UK. So if you're coming to Manchester, it's a good idea to start mailing start to know about the hospitals in Manchester. So let's say there are about 6 or 7 hospitals. So start mailing the medical staffing or HR of all those hospitals. So every hospital has its own website. They've got their email IDs. And all you need to do is email the HR or the medical staffing department that you are interested in a clinical attachment and mention your dates as well. Now, because of COVID, many hospitals had stopped taking attachments, but now they have started again. So quite a few hospitals at least half of the hospitals have started doing that. And I do know friends who are joining one or doing one or have completed one. But there are a lot of hospitals. So again, it's like a job. You need to keep applying. You need to mail at least 40 or 50 different hospitals. The thing to keep in mind is if you're applying for a attachment in London, it is most likely going to be paid attachment. They will charge a fees for that. Outside London, it's going to be free. Most of the hospitals outside London, they do it for free. So if you want to stay in London, that's fine. They will charge you about 200 to 50 pounds. But the easy way to do it is just mail the hospital HR or medical staffing with your dates.
Okay, thank you so much, sir. Sir, by unfortunately or fortunately, just got one more question.
Yeah, sure.
It was, is it necessary that we have to have a research for getting a residency in UK, sir?
Getting a residency, definitely, you definitely need research, because some specialties, they actually use your portfolio score to decide whether you will be called to interview or not. For example, surgery. So for core surgical training, it works like, how it works is you are given a self-assessment. You'll be given a scoring pattern on the website itself. You have to score yourself, and there is a cutoff score. I think last year it was about 48 or 49. So people who had a score above 48 or 49 out of 70, only they were called to the interview. So definitely you cannot make it to the interview without doing research. For a non-training job, it doesn't matter. It helps, but it's okay. Even if you have not done anything, it's fine. That's why I say just do a clinical attachment. That is also okay. People who have not done anything also, they have also got a job. It just takes, it's just a matter of time. It will take longer to get a job. But for residency, definitely you need to work on your portfolio. But that is something you don't need to worry about, because it can all be done while working in UK. It took me about just 4 or 5 months to make my whole portfolio for radiology residency. It's not that difficult.
Okay, thank you. Thanks a lot, sir.
So obviously, if there's any more questions, you can take my email ID. You can message me on Instagram or Facebook. I'm happy to take any questions. And it's been really nice presenting this, and hopefully it will help many more people.
Obviously.
So thank you again for having me here today.
Yes, it was a great Yes, it was a great pleasure to have you, and thank you for taking our time and providing us with valuable information and guidance, sir. Okay. So you can take a screenshot of this, and you can contact sir for any other further details. So now I would like to hand over the session to Dr. Yashashwini for the next pathway.
Okay. Take care. Thank you.
Thank you, sir.
Thank you, Saloni. So today we have Dr. Nachiket Bhatia giving us an insight on NEXT. He's the CEO of PBMCI. He's listed in Forbes Top 10 Innovative CEOs of India and Business World Top 100 CEO of India. Also a TEDx speaker. Over to you, sir.
Yes, hi guys. Am I audible?
Yes, sir.
Great. So hello everyone, I am Nachiket and I am going to talk to you about what is NEXT and how NEXT is going to actually affect you guys. And to be very frank, in the very start, I'm going to tell you something that NEXT is going to be a big mess. It is going to be a big mess because one, that it is going to be a very difficult exam, and two, that we are already at the end of 2021 and there are so many questions that the government has still not answered. So what I am going to give you is a basic comprehensive review about what the whole program is going to be, how the exam is going to be conducted, and how you may prepare for this exam if you're going for that. So the very first thing that you need to understand is, so actually I'm going to share my screen. Just give me a second, please. Yashashwini, can you help me out? I'm just sharing my PPT with you. Is it possible that if you can share it here? I'm not able to do that.
Yes, sir, I'll do it. 1 second.
It's okay. It's already open. So can everybody see this?
Yes, sir.
Great. So basically, the first thing about Next is that Next, unlike NEET PG, is going to be a licentiate examination. They are now copying this style from the USMLE. Earlier, NEET PG was the exam that was, till today, NEET PG is the exam that it is used to get you your postgraduate seat. But from 2023 onwards, every IMG or FMG, Indian medical graduate or a foreign medical graduate, if he wants to practice in India, has to go through 3 processes. The one being Next one, then the compulsory internship in India, and then Next 2. All these 3 things has to be done compulsorily by everybody wanting to have a medical license of India. And this is the biggest thing. And Next one is the exam that you need to clear to get your PG score as well, the PG seat as well. Next one is the exam that you need to clear to get you your temporary license, the right to start your internship, and your PG seat. After that, you will start your internship. And at the end of the internship, you have to clear this exam called the Next 2. This exam, my friends, is an exam that you need to clear to get your PG permanent medical license. This is, again, non-optional. You have to give this exam. So the first myth that you might be hearing is that the final professional is being replaced by the next. Aisa nahi hai. It is not like that. All the 4 professionals for an Indian medical graduate are going to take place the same manner that they used to take place earlier. The biggest difference is now the final professional will not be an external examination, but it will be an internal examination. After crossing your final professional, you have to give this exam called the Next one for your PG seat, temporary license, and the right to start internship. After crossing internship, you have to appear for the exam called the Next 2 to get your permanent license. Before going to Next one, I'm going to talk a little bit about Next 2 because a lot of things about Next 2 are still unclear. But some things which are clear, which are that the syllabus is going to be what you learned during the internship, and whether it is going to be an MCQ based examination or a practical examination, it is still not clear. A list of basic practicals is going to be asked in this particular examination. Apart from that, this exam is going to be a simple pass and fail exam. Next one is going to be a competitive examination, but Next 2, just a pass and fail exam. You will be given a certain percentage. Whoever crosses it, passes. Whoever comes below it has to give this exam only to appear for to get his permanent medical license. Now, the biggest difference between NEET and Next, NEET for today is like a one-day exam, 200 questions. NEET in 2020 was a one-day exam, 300 questions. Next, on the other hand, is going to be a 3-day examination, 6 parts, 540 MCQs in total, and 90% clinical-based questions. This is the biggest difference between NEET and Next. Now, talking about NEET and Next, so basically how Next is going to be framed. Next is 540 MCQs, 6 papers, 3 days, 2 sessions per day. So the first day, as in the first part, it would be the pre-lunch part. The second part would be the post-lunch part. Pre-lunch, it is 120 questions, 3 hours. Post-lunch, it is 60 questions, 1.5 hours. Now, the very first day, you will be having medicine and allied subjects. Now, allied subjects includes everything that can come under medicine: physiology, pharmacology, pathology, anatomy, psychiatry, dermatology. Post-lunch, it is pediatrics. Second day, it is surgery and allied subjects. Allied subjects again include everything that can come under surgery, that is anatomy, pathology, anesthesia, orthopedics. Post-lunch, it is ENT. Third day, it is gynecology and obstetrics. Post-lunch, it is ophthalmology. This is how the basic structure of Next one is supposed to happen. Now, talking about the question pattern. Now, please understand this very carefully because this is the most important part. See, the questions are categorized into 3 parts. The first is problem solving, which is going to be 60%. Second is comprehension and analysis, that is 30%. And third is recall, that is 10%. Now, problem solving question. Let me give you a very simple example. Problem solving question will be, You get a patient, he's coughing and sneezing. What do? You ask him to get a simple test for loss of taste and loss of smell. You ask him to get a test, an HRCT, an X-ray. The X-ray and HRCT show symptoms of infection. Show signs of infection. Then you think that this patient can have COVID. Then you ask him to get a more permanent test, diagnostic test, that is RT-PCR. RT-PCR comes back positive, and you say this patient is COVID positive. So in this question, you had the symptoms, you had the initial results, you had the definite test results, and the question is, what do you think is the most probable diagnosis for this patient? A typical example of a problem-solving question. You get the symptoms, you get the initial results, you get the definite test results, and then they ask you, what is the diagnosis? You solved a problem. Comprehension and analysis. You get a list of X-rays of around 10 patients, and then they ask you which patient has the highest infection in the lungs. You basically comprehend, you analyze, then you mark an answer. Comprehension and analysis. Recall base. Recall base is basically testing your memory. You get a picture of an instrument, let's say an instrument from surgery, and then they ask you, what is the name of this instrument? Checking your rectification memory. They ask you this, and then they ask you, what is this? This is a perfect example of a recall-based question. 10% questions are going to be from basic sciences, that is first and second year subjects. 10% questions are going to be from public health, that is PSM. So this is the basic structure. Now the biggest myth, again, the second biggest myth which I can say is that now you do not need to study first and second year subjects because the syllabus only states clinical subjects. My friends, that is the most incorrect thing that you can do in your life. And I can prove it to you right now. I want everybody to have their hands on the chat section. I want everybody to have their hands on the chat section, and I'll ask a simple question. Broca's area is responsible for what? A very simple question. Broca's area is responsible for what? Exactly, Kenneth, Shamika, very nice, guys. Now, this is a neat pattern question from 2017. Now, the second part is, a 36-year-old man comes into a clinic with a complaint that he's having difficulty while speaking. Which area in the brain can have the most probable lesion? Answer. Which area in the brain can have the most probable lesion? Answer. A 36-year-old man comes into a clinic with a complaint that he's having difficulty while speaking. Which area in the brain can have the most probable lesion? Yes, Atharva, perfect. It's Broca's area again. Which subject is this question from? Which subject is this question from? We have physiology from Kenneth. Anybody else? We have Zishan saying neuro. We have Shamika saying neuroanatomy. Atna, neuroanatomy. Guys, understand it. If it would have been anatomy, I would not have asked this question. This is a medicine question. Which anatomy, in which area of anatomy do you see an OPD coming in? If you categorize this question, it comes under medicine, but the crux is basically pure anatomy. What I'm trying to prove right now is that if you're thinking that only reading medicine can get you to solve anatomy questions, then I'm sorry, it won't happen. And nobody's going to teach you Broca's area again in your medicine days. So every clinical subject that you're looking on, they have a crux in pure first and second year subjects. Pharma plus physiology in a clinical setting is called medicine. Anatomy plus pathology on a surgical table is called surgery. If you do not know anatomy, you are not supposed to know either ortho or surgery. So if you have to start a preparation for next, which of course everybody has to do, you need to start from the very first year, then move to second, then third, then fourth. Please do not skip directly to clinical subjects. Because unlike NEET, there are no more single liners to save you. In NEET pattern question like single liners, a medicine question is defined as what is the range of hyperglycemia? What is the range of hypoglycemia? This is a medicine question. But in next, you will be having pure clinical questions integrating multiple subjects. You will be having, for example, that COVID question again. You have loss of taste and loss of smell. That's anatomy and physiology. Coughing and sneezing, again, anatomy and physiology. Moving on to HRCT X-ray, that's pure radiology. Moving on to RT-PCR, pure biochemistry. Then COVID, microbiology. So 6 to 7 subjects were integrated to make one question. So to answer that question, you need to have a knowledge of all the subjects. Skip one and you are out of the whole question. Despite reading the other 5, if you do not know even one subject, you are out of the game. So that is the biggest myth that I'm going to break, that you have to read all the 19 subjects to conquer next. Nothing less, nothing more. Now coming to a bit of summary, the next is going to held in 2 sessions, next 1 and next 2. Next 1 will be held first time in 2023. 2018 batch will be the first batch to give the next one. Both the exams have to be given compulsory by both IMGs and FMGs. Number of attempts is still not clear. Negative marking, most probably negative marking will be there, although it is still not clarified by the government. Now I have one more concept, which is, I think it's very important that you listen to this because it might happen. So the concept is that what happens when you clear next one and you want to start your internship. So the government is giving you 2 options. The first is you choose a PG seat, you start your internship, you give next 2, you start your PG. The second is you say, no, I want to practice as a plain MBBS, I want to go for IES, USMLE, PLAB, maybe. So the government says that you lock in your score today, like MLE, and for the next 3 years, the score remains with you. For next 3 years, you can appear in any subsequent counseling, show this score, and the government will give you the seat available at that score. Okay, and after the lock-in period gets over, like after 3 years, you can again give the next one to get a better score or something. But the second is, what happens when you clear next one, but do not get the set of your choices? I mean, your score is not good, you are not getting a PG seat. What happens then? You have to drop 1 year and then give the next one again. And you have to choose either of that given 2 above options, that either start a PG seat or lock in your score to start your internship. That is the only way you can get a chance to get a better next one score before internship. After internship, you will have to wait for 3 years. That is the lock-in period to give the next one again. So that, my friends, with that, I would like to conclude my session on next 1 and next 2. If you have any questions, you can just ask me on the group chat box. I will put my Instagram
Thank you,
ID.
sir, for summarizing next. We have a few questions predefined. So,
Sure.
how to prepare for next as an FMG student?
I think for FMGs, the first thing that I want you to understand, I'm really sorry. Yes, for FMGs, I really want, first thing that I want you to understand is that FMGs have to change their thought process, first of all. I've been talking to a lot of FMGs and they are still into that rectification mode, because earlier MCA screening test was a single liner examination. So more than NEET PG, FMGs are in trouble because now they have to learn concepts. And if you do not know concepts, my friend, you are not going to achieve anything. So the first thing I would like to tell you is that you have to start as early as possible. And you have to start with the first year subjects. For example, if you have eGurukul and you are reading the FMG videos from our app, I would suggest you how to read that. I'll ask you to first watch first to 4 videos, then open BDC, and then watch read the same topics from BDC. Then watch 5th to 8th video, and then read the same topic from BDC. This is the only way to make your concepts. Now, when you do that 1st to 4th and then the same topic from 1st to 4th, now when you read 5th to 8th video, when you watch 5th to 8th video, it will be like you are watching a Harry Potter movie and you have read the Harry Potter novel and now you are watching the Harry Potter movie. You can imagine what the bones look like. So this is how you have to read in the very first start. And then with that, in eGurukul, we have given subject-wise, like topic-wise question bank modules. So you have to add daily Q bank module into your academics. Like watch 1st to 4 videos, then read 1st to 4 from BDC, and then do Q bank of 1st to 4 video. We have a Q bank attached with every video. So this is how you prepare your concepts and learn how to use your knowledge to implement it into questions. I mean, end में आके you have to solve questions only. आपको कितना आता है, कितना आप पढ़ के आए हो, इससे कोई फर्क नहीं पड़ता. फर्क ये पड़ता है आप कितने क्वेश्चन सही मार्क कर सकते हो. So change your thought process, stop rectification, understand the concept. If you do that, you can very well clear your FMG screening in next one only. And then in the very same exam, if you crack a better rank, you will be getting a PG seat only. So a win-win situation for FMGs.
So if a student passes next one and doesn't manage to secure a seat for PG, then the next time he gives next, will he have to give next two again?
No. So basically what will happen is that if he's not getting PG and if he drops again, then he first has to give the next one. He cannot start his internship. You have to give the next one again. Choose either the two, either choose a PG seat or lock in your score. Then he can start his internship and then he has to give next two. This is how it will happen.
So if you lock in the score and then if you don't manage to get a PG seat even after giving X2, so what's the time limit when you can repeat the exam?
What the government has superficially stated is 3 years. And for 3 years, the score shall remain with you. And after 3 years, you can reattempt the exam.
Okay, so how should one perform in next to take up MS after MBBS?
I think for a competitive exam, Yashaswani, that you have to perform as good as possible. Every year you will find that people are topping the last year score. So there is no, I mean, you have to give your 110%. There is no even a degree less for this.
And will next also replace IMICT?
With the latest draft that the government has put out, it has clearly stated that next one shall be the only exam responsible for putting students into PG seats. So by the looks of it, they might integrate INICT with that.
Okay, sir. And this is a sensitive question as so now that reservation is also in consideration. So what's the scope for general categories?
And that's a political question that you have asked me right now. So I think the scope is the same as today. The scope is not going to improve anyhow. Reservation is a part of the Indian culture now, so it is still going to be there. What I can ask you to do is that, however less the percentage is, every student has to give it his 100%. I mean, about reservation, I can't really say anything. You might understand. Hello.
I guess we can take up some questions from the chat box.
So I think it will be one time only. Next exam will be conducted one time only. I have to appear for next with the fresher batch student. Yes, for the 17 and senior batches in 2023, you have to give the next one only. And when the result comes out, 17 and senior batches have a filtered result in which they will appear only. You will get your own rank one and everything. You will start your PG seat in 2023, whereas the 18 batch will start its PG seat in 2024. So that is how the senior batches will be accommodated in 2023.
Thank you, sir.
So, all right, guys, thank you so much. If you have any more questions, you can contact me on dr.nachiketbhatia on Instagram. I'll be more than happy to answer your queries. Apart from that, I believe Yashaswini, a very great experience. Thank you so much.
Thank you, sir.
Take
Thank
care.
you, sir, for summing up on next. It's been an honor having Dr. Malki sir and Dr. Shitanshu Kalani and Dr. Nachiket Bhatia for helping the future aspirants choose their own pathway. I'd also like to thank the regional heads and VESs to coordinate this panel discussion. And
So our next event is at 6 p.m., which is Artificial Intelligence in Global Surgery. So I'd like to request everyone to tune into that at 6 p.m. because we are already done with our panel discussion now. Thank you. Thank you everyone for joining us.
Hello, can you guys hear me?
Hello.
Yes, I can.
Great.
So we'll just wait for a few minutes for the delegates to join, and then we can go. There is no way out. Hello, everyone. We'll just wait for 2 more minutes for the remaining delegates to join, and then we'll start the workshop. Good evening, everyone. I'm Smriti Venkatesh, and I would like to welcome everyone to today's keynote session, Artificial Intelligence in Global Surgery by Dr. Nicholas Amorphous. Some of you all have joined us on Zoom today, and many of us are watching. Many of you all are watching us on YouTube Live, so a very warm welcome to each one of you. Dr. Nicholas is a run-through surgical trainee in urology, undertaking his training in the West Midlands DND. He underwent his foundation training at Lister Hospital, Stevenage, and his medical training at University College in London. He holds a bachelor's degree in surgical sciences and has undertaken 2 internships in the United States at Massachusetts General Hospital and Stanford Hospital. He has a keen interest in academic medicine and the integration of technology in the health sector. We are incredibly honored to have Dr. Nicholas here today, who will delve into the world of AI and its impact and massive significance in the future of surgery. Thank you for joining us today, sir. Before we begin, all delegates, please ensure your mics are on mute. And if you have any doubts, feel free to put them in the chat box. We'll be asking sir all your doubts at the end of the keynote session. Also, we would really like you all to keep your cameras on with the RGS virtual background we sent to you on the delegates group. Without further ado, let's begin with the session. Over to you, sir.
Thank you very much. Thank you for the invite, and thank you everyone for joining us today. So essentially today will be a run through the artificial intelligence global surgery. So the aim of the lecture will just be going through the basics of what artificial intelligence is, and then covering how it affects our day-to-day lives, both in general and in surgery. I'm just gonna be sharing my slides right now. Can you see them now?
Yes, sir, we can.
Yeah, perfect. Okay. So again, it will be a run through everything. If anyone has any questions at the end, they're more than free to ask. And obviously, if I'm not communicating properly, please feel free to stop me. So, I mean, the term artificial intelligence is being thrown around a lot, but what is truly artificial intelligence? So there is many misnomers that are being used currently, but essentially artificial intelligence is a series of logical learning algorithms that are employed to allow computers to execute tasks similar to the human brain. So essentially they can mimic human intelligence in decision making, and in the future can potentially evolve to a level where they can think in a way far superior to human thinking. And that's where the concern comes in essentially. So it can be subdivided into 2 broad subfields called machine learning and deep learning. I don't know why. So machine learning and deep learning. So machine learning is what they used to do about 30 years ago. It's basically, it's when AI systems have the ability to automatically think without explicitly being programmed to do something. So they automate a task, and usually that's a menial labor task like calculations and so on. Now, deep learning is when basically the machines are able to make decisions entirely independently. So they learn through their mistakes and then progress to having this sentient being. So, So there's different terminologies again that I would like to just cover before we move through. So there's a term algorithm, which essentially means a set of unambiguous instructions that a mechanical computer can execute. Many AI algorithms are capable of learning from data and can themselves write other algorithms, which is what we talked about, being a bit more sentient. Artificial neural networks, which is when it's basically inspired by the biological neural network, where the different neurons are firing to each other and forming connections like the human brain. Data mining, which is going through large data sets to generate new information, similar to how doctors do when they're doing different audits or research on a day-to-day basis, as well as cloud technologies, which, as we all know, like Amazon Cloud Technologies, just refers to the use of remote service in order to store and process data. Now, sorry, I'm having a bit. So there's different types of artificial intelligence: weak, strong, and super intelligence. I've already covered them pretty much when we're going through it, but just to reiterate that weak is repetition of menial tasks that have a narrow spectrum of activity. Strong AI is when machines are able to apply intelligence to any problem and solve it, essentially similar to the human brain. And then super intelligence is when the intelligence far surpasses one of the brightest and most gifted human minds. So how can all these be applied in life? So there's a lot of applications of artificial intelligence. in our day-to-day lives that we don't even realize. Anything from virtual assistants on our phone, like Siri or Cortana, or social media. That you search for things and automatically it appears what you want to search for, or something like that. Transportation, you've seen that the movements that Uber is doing in terms of autonomous car technologies, as well as Google and Waymo, developing those kind of machines that can learn what's a human, what's not a human, and how you should stop just before something's in front of you, something like that. And then in healthcare, which is what we're going to be focusing on, which essentially initially started off with helping in drug discovery. So it's a very tedious task where initially with the start of penicillin, you had penicillin that pretty much covered all antibiotics, and then they started to develop different antibiotics by fine-tuning the chemical compound a bit, just to cover more of a broader and narrow spectrum of bugs. But then what they realized that they're having an incredible amount of difficulty in developing new products, because they have the number of drugs that actually end up in market is a fraction of the ones that are being produced. And the only way to produce that many drugs is having AI help in that process. And then you have things like robotic surgery, which I believe you had a workshop on it already, but it's one of the first kind of true involvement of AI in surgery. And that's the only true AI in surgery. We're trying to move towards that field, but it's very difficult, as you can imagine, because of a lot of ethical boundaries. So how does the AI work? So the aim of it is to learn, predict, and improve. It starts with unsupervised supervised task-driven journeys to unsupervised data-driven learning, and then finally reinforcement through learning of errors. So in medicine in particular, if we want to apply it to medical diagnosis or medical imaging, we initially have, we code what are the symptoms leading to diagnosis in a PC. We feed that into the PC and into the algorithm, and then eventually we start to recognize different presentations of a diagnosis of, let's say, appendicitis. It can be very clinical diagnosis, but at the same time, there's a lot of symptoms and signs that suggest that it's clinically, that diagnosis. So through that process of evolution, you can make a system where it's much more accurate than even humans. So early history of everything. I'm not going to bore you too much with this. I found it very interesting, so I'm just going to throw it in. So as we know from the movie Imitation Game, Alan Turing was really the founding father of modern science that put everything in motion by developing his machine that broke the Enigma machine. But he also proposed a very important thing called the Turing test, which essentially the idea that you can assess a machine's ability to exhibit intelligent behavior equivalent to or indistinguishable form from that of the human mind. And the way he proposed that we'll do that is by having a virtual conversation between a human and the computer, and see if a third party, a third human observer, can confidently say which one's human and which one's a computer. And what we're realizing now is that it's getting much more evolved to the point that you can't really tell the difference between human and computer. And then John McCarthy is also one of those people that have helped contribute to this evolution of AI through coining the first term of artificial intelligence in this 1956 Dartmouth Summer Research Project, where about 11 researchers participated in. So what's the current size of AI? Again, I've covered this a bit, but I think we're just going to focus on robotics mostly today, but really it's part of our everyday today life, and we don't even realize how ingrained it is nowadays. So the timeline of AI, we've mentioned a few things. I think the one that put in the map was a 1997 IBM's Deep Blue computer that managed to beat the world chess champion Garry Kasparov. But then, as we'll notice, in healthcare in particular, we've had gradual developments over the years, starting from 1956 to this day, starting with antibiotics and then drug discovery and personalized healthcare that will have a huge impact on how we operate and how we view our patients, how we manage our day-to-day tasks. So again, just to prove a point, even without realizing these are that there's not these many companies that are actually involved in healthcare and artificial intelligence in healthcare. Most of them we don't even know because they're working in the background, but it's things that we need, when you go to work every single day. And things like personalized genetics, that didn't happen 20 years ago, but obviously with the Francis Crick Foundation leading the field of cutting down costs and developing personalized DNA analysis, you can have these technologies, or like things like Fitbit or the Apple Watch that track health. That's a form of AI that you think, oh, it's just tracking everything, but it's AI. And then you can, for a clinician, for example, a patient comes in preoperatively, they have atrial fibrillation. You can actually use the Fitbit, use the Apple Watch to see at what times it's going off. Is it a relatively stable AF, or is it unstable AF? Will that affect my patient when I take them into theater, or will it not? So it's these kind of things that you can easily use in technology to make your life easier as a clinician. Things like telemedicine, during the age of COVID, telemedicine was there before, a few years ago, and it was getting traction, but with COVID, it has radicalized the way we manage our patients. Obviously, it's a bit more difficult in things like surgery, but a lot of the examine a patient, for example, if they have a hernia, or if they have specific stable diseases, because you want to see how it affects their life rather than if they have a condition themselves. Because I can do a CT scan or an ultrasound and say, okay, he has a hernia, it's a big defect, or it's a small defect. But does it affect the patient? If it affects the patient, I'm still going to take them to theater. If it doesn't affect them, will I truly expose an 85-year-old with a hernia, but also a background of heart disease, diabetes, problems with the COPD, and so on, to a surgery that can potentially, have a high mortality risk? Not really. So it's these kind of things that you have to consider to play. Or medical records. I don't know how it is in the hospitals that you go to see patients, but in the past it used to be all paper. But the problem with all paper is that there is very little accountability of actions, and you can't often read the handwriting that people write. You can't tell the plans. If I'm in a different part of the hospital at home, I can't really track my patients. But with online medical records, you can do that. I can be at home, can check up on my patients, see how they're doing post-operatively, and sleep better at night rather than texting a junior and saying, how is this guy doing? Is he good? I'm a bit worried about them. So it's every little part that affects our life. Now, it's really, it used to be science fiction, but now every day you see it, it's becoming part of our day-to-day life. So things like early detection of diseases. So one of the things that really made a difference is in breast cancer, essentially. So we used to do a lot of mammograms, and a lot of patients would be told, you potentially have, breast cancer, and then they would undergo a biopsy, and the biopsy would say it's something benign, so they don't have anything wrong with them. And the problem was that even though we are trained to distinguish potential signs of cancer, we are not perfect. The human mind can't spot all the small details in a scan that will tell you if it's benign or if it's malignant. But by training an AI algorithm into these kind of images, you can train them into, let's say, 1 million images, and then they can much better recognize something abnormal, something normal. Obviously, the clinical decision making is still very much part of it, because the computer can't tell emotions, it can't tell, how much that affects someone and have those clinical decisions. But it can help a lot of with the crust of all things, that is this actually benign? Is this actually malignant? Do I have to urgently do something about it, or can I wait on it? Can I sleep on it? Can I leave it for 3 months or so and see how it gets on? Because a lot of things improve. Like if a woman has a breast cyst, it's a very benign condition. It can often improve on its own depending on the menstrual cycle. However, if I take them to theater, I've already exposed them to something. I've made scar tissue over there. So they are going to be risk of complication, all these things, which are not good for patients and affects their state of mind. So companies like Google's DeepMind is working in partnership with clinicians to develop these solutions to make it easier for us to do what we need to do. So then again, medical imaging. So particularly medical imaging, you can't train a PC to do it again and again and again and be able to distinguish all the small variations that we as clinicians cannot, because number one, a lot of us are still trainees, so we won't have as much experience. And number two, we don't have the time to deal with the increasingly amount of workload because there's an increasing aging population. The number of doctors doesn't really increase at the same number. So we are constantly finding ourselves understaffed in every sort of specialty. Also decision making, things like Dr. AI that was developed by Deep Health as well as Babylon. They enable virtual consultations, and they're allowing AI to triage patients into whether or not they should attend ED, urgent care, or primary care doctor. So a patient, for example, that says to the digital consultation, have sudden onset abdominal pain that goes to the back, that will think, well, it could be a triple A rupture. So that would say you need to go to ED urgently. But if it says, I've been vomiting, having epigastric pain that relieves after eating, or, it's worse after eating or lying down, it will say, please see your primary care doctor. So it's allowing surgeons to do what, allocate their resources much better so that they see the patients they need to see and then leave everyone else to be seen by someone else more equipped and has more time to see them. So then moving on to treatment, again, it's, you see a lot in orthopedics, I would say. So you can do, AI can be used to improve preoperative planning and analyze the images in order to be able to tell, how much is the gap between the bones in order to fit, or in order to analyze which kind of, metallic structure you can install in it in order to be able to have a better joint mobility or, have reduced pain, reduced complications. So you can analyze all the different details like bone profiles, the bone anatomy, the gaps, defects, in order to come up with a better solution. And then the clinician, and then the surgeon can basically go and say, okay, I'm going to use this equipment, I'm going to go in, I'm going to fix it, and then the patient will have a better outcome. So it helps out with preoperative planning as well as operative planning. Then end-of-life care. In surgery, we don't have this as much because usually for a patient to be operated on, they have to be fit enough to undergo surgery. So we don't often put palliation decisions in for patients. However, it does happen. If you have a patient that has triple A rupture or they have severe bowel obstruction, they're not fit for surgery, you will try to make them comfortable. And a lot of the times they might, their survival might be hours, days, or it can be weeks. And depending on the situation, these patients still feel lonely. And again, I'm going to bring back COVID into play. During COVID, a lot of patients were left on their own. They were very lonely. And that, again, you don't want someone who's potentially dying in the next month or so, suffering through the whole month just because they're alone. So things like AI can allow artificial robots to interact with the patients and then relieve that sense of loneliness. And then in terms of medication management, you can remind them to take the medications and can also check whether or not you took the right medications at the right time and remind someone like your carer to come in and check on you if you haven't, because something might have happened. And then things like molecular epidemiology can identify different drugs and genes that contribute to multifactorial diseases. So one of the most common conditions you see in general surgery would be, for example, Crohn's disease or ulcerative colitis, where they develop adhesions, bowel obstructions, perforations. So if you can identify genes that can tell you which patients are more predisposed to getting these conditions, you can treat them much earlier, get a better control on them, and reduce the risk of complications and reduce the risk of them having to have surgery in the first place. Because once they start having surgery, a lot of them keep coming back and the risk of complications piles up. Then in training, obviously we as clinicians, we're always trained in this OSCE kind of manner where you're given different virtual scenarios and you have to act them out. But how does AI come into play into this? So you have these models where they're having incredibly complex physiology and they can adapt their physiology on their own as the scenario progresses. So instead of a clinician telling you, okay, this patient now decides, or this patient developed abdominal pain, the AI will act it out, and they'll say, oh, and their SATs will drop, and you'll be able to do it real life, as if it's real-time decision-making, just to put you more into the sense of this a realistic scenario, rather than just someone telling you, oh, yes, this patient became a bit more unwell. It's not the same. It's just putting you more on the spot. It's challenging you in more ways that you can imagine, and makes you a better clinician for it, a better surgeon as well. And then, again, AI robotic, which is a big one. It's a big one for surgeons, right? So when the Da Vinci robot was invented, initially people didn't want to use it. It was a steep learning curve for people to become better at it. And, a lot of people didn't want to do it because it's you spend 20 years or so training, and you trained on a particular thing. Does everyone want to become better at something new? Not really. But it has been shown to improve reduce complications, improve patient outcomes, reduce hospital stays. So it has become more and more part of our day-to-day life. And, initially was used mostly for, urology surgeries, prostate cancers. Then it has started to be used in gynecological surgery, general surgery, ophthalmology now. So more and more specialties are using it because they're realizing how much benefit it can add. And in terms of how you can add that benefit, there's a lot of ways. So it can help with AI, can help with the preoperative planning, because it can help with port allocations. Because if you can imagine, when you put the ports in, there are better locations than others. So depending on the patient's physiology, some port locations will be better to use than others. Then you can analyze the scans as well and pose your robot in such a way to have a better outcome. Then in terms of the operative records, you can use AI combined with AI to superimpose images. So for example, you can add dyes or add CT scans and then virtually be able to tell which structures are passing around, let's say the prostate, where are the vas passing through, where is the seminal vesicles, to minimize damaging those structures, and then where is the rectum, where minimize rectal injury. So it can really reduce the risk of complication in that way. So the other way it can help is through augmented reality combined with AIs, can do object detection and scene labeling, as well as, I don't know if this was shown in your other workshop, essentially a clinician who's miles apart, they could be in New York and you're in India, they can use their PC essentially and just guide you through where you should be going, just by pointing it out for you and saying, okay, these are a bit abnormal, I would stay clear of it, I would go a bit more lateral, and just dissecting that plane, go around it, and so that they can guide you, which will be I guess it will be the step before AI truly having that role for you. So you need to have, as we said, supervised structure initially, where a clinician will do that, and then the AI will learn from it, and then eventually you won't need anyone around because you'll have AI telling you and guiding you where you should be going and helping you in that way. And currently, there's a lot of companies that are developing technologies to assist with robotic surgeries. So the one that I particularly like is surgical theater, which is essentially what neurosurgeons use. So they can use the brain, they can use 3D structures of the brain that are taken through MRI scans, combining MRI scans, and then have a virtual environment, a virtual room, so to say, where they can cut and practice how they operate, similar to Grey's Anatomy. I don't know if anyone watched Grey's Anatomy, one of the episodes where they essentially use that virtual brain and they say, okay, let's practice again and again until we get it perfect. It's not there yet, obviously, but this is where they're heading. This is what companies like surgical theater are trying to do. They're trying to do the impossible. It all starts from somewhere. Now it's very rudimentary, but in 10 or so years, 10, 20 years, we might be at that level where we can practice this out, and every step we can map it out so we can minimize the risk of complications. And then there's things like immersive touch, which pretty much do the same thing, but they do it through Oculus Rift, which I know a lot of people have used in the past to play video games, essentially. So they do the same thing, but it's a bit more basic compared to surgical theater. Obviously, there's a lot of challenges to this artificial intelligence, however. So even though there's a lot of positives, there can be a lot of negatives. So initially, the negatives were, things that why can't we develop it? And things were like computing power, storage cost, and data availability. But as we're moving more into the tech age, where you have computers that are increasingly faster and better, the storage costs are coming down because of more availability of servers, essentially, and database is becoming increasingly available through an exponential rise of connected devices, because pretty much everyone has a mobile phone, right? That's a sort of PC on its own. Everyone's using social media, so that's more data that are being uploaded into the internet all the time, and that's data that the AI can use in order to become better. And then finally, financial. So about 20 years ago, there was almost no investment into AI. Currently, there's studies that show that it's between $5 and $10 billion being spent on AI alone every year, and that's expected to improve, to increase year on year over the next 20 or 30 years. So the future is very bright for AI. Moore's law basically says that you can exponentially increase the number of complexity of PCs. We're developing things like quantum computing, where, if you can imagine, they used to say, oh, you have a supercomputer. Quantum computers makes the most advanced supercomputers looks like child play. Like, it's miles better than that. So our ability to develop more complex algorithms becomes miles better as well. And then finally, the challenges that are going to come. So particularly is medicine, what prevents everything from advancing very quickly is that socioeconomic impact as well as ethical concerns. So socioeconomic impact, a lot of surgeons are saying, including myself, when Da Vinci came around, was, well, is it going to replace me? And the answer is no one knows, because automation initially brought about a change where menial labor was being taken over by PCs, but there was still someone supervising it, and the net absorption of jobs was pretty much the same. It's just you could do more things with technology, and we could advance much more. But we're finding now with these kind of things, they're also taking mental tasks away, which are tasks that we as clinicians, we spend so many years studying at uni to become better, but the PC is just automatically programmed to have all that knowledge. So what's our purpose? What's our role to play in that field? So these things have to be worked out, or things like data and privacy protection. What's stopping hackers from stealing all that data, or taking control of autonomous cars or robots intraoperatively, and killing someone off? No one knows. So these are concerns that arise, and then security concerns as well. So just to come to a conclusion, I know I've rushed through a bit, but obviously I'm leaving a bit more time for questions. AI is a promising tool to transform healthcare, but there's significant barriers, as we explained before, to develop this and make sure that it's done in a safe manner. But it can have an impact on clinical decision making, making our life easier. It can enhance the infrastructure of healthcare and bring about automations that can optimize production, distribution, as well as utilization. And thank you. Any questions?
Thank you so much, Dr. Nicholas, for such an insightful talk. And we definitely learned a lot on AIs. And like Dr. mentioned, back in 1950s, the father of the field, John McCarthy, actually described the artificial intelligence as a task performed by a machine. And based on the doctor's talk just now, it's really impressive to see the progress and how far the AI system developed that is actually capable of doing superhuman performance, especially in the field of global surgery. So with that, thanks again, Dr. Nicholas, for such a wonderful and fantastic talk on this topic. And now we shall move on to the Q&A session. So to all the participants, if you guys have any question, please type out in the chat box. So there's one question, Doctor. So what is your perspective on generative AI?
Sorry, regenerative AI.
Yep.
So it's progressing a lot. So initially they used to do it a lot with the pancreas, where they wanted to treat diabetes and solve that. There have been studies where they are getting better at it. But I mean, it would be a change breaker, because currently we have a shortage of transplants. So it would truly revolutionize everything. But I think we're a long way off, because even though they're trying to figure out how to develop organs, we don't know how they're going to respond in an in vitro first, and then in vivo simulation. But it would be a game changer if we can get it done.
Thank you, Doctor, for that. So we have another question. How can we protect patients' privacy when using AI in healthcare?
So that's one of the biggest challenges. So even though you can protect it in a sense by holding it in a secluded environment and trying to have all the safeguards in place, you can never get rid of hackers. So we've seen governments being toppled over by hackers and demanding ransoms for it before they release the data. So it's one of the things that I don't know if we can protect it. That's why it has to be a very cautious approach before we can move to that essentially.
Thanks for the answer again, Dr. Nicholas. So while we are waiting for the participant to come in with more questions, so even I have one question to ask Dr. Nicholas. So Doctor, when knowing that global surgery, when we talk on AI, that is actually related to global surgery, and we know that global surgery is a field that actually aim for provide safe and affordable surgical care, especially those from lower and middle income countries, because we know that 5 out of 7 billion people in the world that not having proper access to safe and affordable surgical care, and most of them from lower and middle income countries. And we have seen that many AI actually being deployed and used in high income countries. So how Doctor think that lower and middle income countries can actually buy in and map out the usage of AI in their countries?
That's actually a very interesting question. So I was gonna mention it briefly, but then I think mostly that should have touched on it. As you said, it's mostly focused on high income countries which can afford the technology. However, well, sorry, 1 second.
Yeah, sure.
Apologies for that. So how can we actually prevent against? So there is ways that you can use that technology to make life easier first. So there's things like so there's in-depth diabetic retinopathy screening, for example. You have patients undergoing imaging, right, retinal imaging. A lot of the times you don't have the necessary staff to be able to interpret those images and give appropriate advice to patients. A lot of the patients in low-income countries, they still have this imaging, but they don't always have the doctors to do all that, interpretation and management. So you could eventually, by having an AI program, they can automatically recognize all the abnormalities and give the appropriate advice to patients. So the government, for example, buys that particular software and it deals with all the diabetic retinopathy patients, and you don't need doctors to manage those patients. So those doctors can be better employed into doing the task no one else can do, essentially. So it's very difficult, because unless the quality of life improves to such a level for them to be able to afford robots and everything else, that would be the only way that they can truly use AI, by basically piggybacking on the technology, essentially, the softwares out there.
Thank you for the answer, Doctor. So there's another question from the participants. Are there certain conditions where AI would be preferred over the face-to-face interaction with patients and vice versa?
Well, I don't believe so. I think that's a one thing that for now, I mean, it can change in 10, 20 years time. But for now, I don't think that's going to happen, because even though you can train a computer to recognize images, and it's getting better and better at it, you can't train human emotions, and you can't train empathy, because it's a much more complicated thing than just training them to, this is good, this is bad. It's not just as that. It's a fine line. It's a constantly shifting fine line, and because of that, I think obviously some patients would prefer to have that emotionless interaction, but for some things, just because they want the quick answer, they want it now. But I think for other things, you wouldn't want it. You wouldn't want, for example, a PC to tell you have a bowel cancer. I don't think it'll be just, I don't think that it's gonna be to that level, because you need to prepare a patient to tell them, something's coming, and then give them the bad news, and then give them time to develop it. And I don't think those kind of things can be taught at this stage.
Thank you, Doctor, for the answer. And we have a follow-up question on the generative AI. So the participant asks, when I say generative AI, I specifically wanted to ask about the generative adversarial networks and the models with discriminators and generators from use in reconstructive and plastic surgery to use in general surgery for not just 3D modeling.
Sorry, can you repeat, because the line was cutting off a bit? I do apologize for that.
Yeah, sure, Doctor. So the question is, when I say generative AI, I specifically wanted to ask about generative adversarial networks and models with discriminators and generators from the use in reconstructive and plastic surgery to use in general surgery for not just 3D modeling.
Okay. I mean, I'll be honest with you, I'm not 100% sure. I'm not exactly sure how advanced it is in that level, because it's not something I have a lot of exposure to, being a urology trainee, to be honest. I had some exposure in everything else, but not as much in that, so I wouldn't be able to 100% give you an answer for that, and I do apologize.
Okay. So I've also have another question to ask, Doctor. So, Doctor, as we know that rural surgery is also a part of global surgery, and we are aware that they are facing many challenges, such as lack of infrastructure, equipment, lack of numbers of surgeons, etc. So, my question is how AI can actually contribute to this resource-limited setting, especially in this post-pandemic era.
So, I think one of them I think I've mentioned. So, initially, you have, first of all, clinicians. So, in every emergency department across the country, in every country, you have someone triaging patients. That's one doctor that's there 24 hours a day, but their sole task is to triage patients. Right? And tell them, okay, you're going to go to minors, you're going to go to majors, or you're going to, basically, I mean, they might say, oh, you could go to your GP essentially, if it's very, very busy. That's the triage. Just from that, you can use AI, similar to what Babylon is doing, to say, that's one doctor less for that particular purpose. And then for medical diagnosis, so if you can imagine, you can have one doctor taking an hour to analyze all the data that are in the patient's investigations. But if you have an algorithm to analyze all that data and have a summary, a clinician can spend 10 minutes on that instead of an hour. That's 50 minutes extra gain. That's 50 minutes that you can see a patient instead of wasting on doing all the admin work. Or again, electronic healthcare records already slimmed down the time a lot, because you don't have to go to multiple parts of the hospital to read what someone has written. You can easily look at it online and see, okay, that's how I manage a patient. So I think it's small steps in every aspect of a patient's journey that eventually add up to a large number of hours that are freed up for each clinician to be able to manage more patients, because I think we will never have enough clinicians, and we're already having a deficit of clinicians every day, because a lot of other fields are requiring an increasing amount of educated workforce, like tech. A lot of people that are smart people, they do decide to go to tech instead. So, you know, medicine is not the best profession like it used to be 20 years ago. A lot of people are choosing, you know, lifestyle in tech where it's maybe it's a bit more easy. You don't do the night, you don't do the on calls. You know, it's a bit more family friendly. So there's a lot of reasons for that. But I think it's, to answer your question, it's a lot of changes in a lot of the steps, and then it just frees you up more than doing everything for you.
Thank you so much, Dr. Nicholas, for answering that question. And I can't see any more questions from the participant. So with that, I would like to thank Dr. Nicholas once again for delivering this talk and clearing all of our doubts. And to all the participants, I hope you guys had a great time. And we have actually come to the end of this talk. It's been my pleasure to co-moderate this session. And well, to wrap up our session, a photo shot is a must, right? So I request all the participants, if you're comfortable with it, please turn on your camera for a brief photo session. And Doctor, if I may ask, can you stop sharing the screen?
Of course, yes.
Thank you very much, Doctor. So Sneha from the team will take the picture. Sneha, okay, so the count of 1, 2, 3. Okay, we have another participant who joined. Let's go for another one. So let's go for a freestyle, maybe with a mini love. In the count of 1, 2, 3. Awesome. So thank you very much to all the participants who actually joined for the photo session. With that, thanks again to Dr. Nicholas and everyone for joining us. And a friendly reminder to the delegates, it's time for you guys to have a cup of tea or maybe coffee. And I hope everyone will attend the closing ceremony, which will begin in 30 minutes time. So see you guys and take care.
Thank you.
Hello, everyone. A very good evening to all of you and welcome to our closing ceremony. We'll be beginning in exactly 5 minutes. Let's just wait for the others to join. Thank you. Good evening, everyone. I'm Smriti Venkatesh, Administrative Director and Workshop Head at the Global Surge Network, and it gives me great pleasure to welcome all of you to the closing ceremony of Revolutionizing Global Surgery, our 3-day annual International Surgical Conference. This year, the beginning of the RGS conference was marked by the scientific competitions. So I would now like to call upon Tanvi, the scientific team head, to announce the much-awaited results of the scientific competitions. Over to you, Tanvi.
Thank you, Smriti. I would request Kapil to share his screen for the results.
Can someone allow me to enable to share my screen, please?
Kapil, please try again.
Okay, thank you, Kapil. Next slide, please. So the winners for the research presentation are, the first prize goes to Sai Kiran, and the second place goes to Raghunathan Ramanandan. Next slide, please. So case presentation in oral format, the winners are, the first place goes to Yashjot Kaur and the second place goes to Darshan BM. Case presentation in poster format, the winners are, the first prize goes to Ritik Salva and the second prize is to Prateek Gond. I would like to congratulate all the winners and even the participants for getting selected to the final rounds. Thank you. Over to you, Smriti.
Thank you, Tanvi. Congratulations to all the participants and winners of the scientific competition. Over the last 3 days, we had delegates joining us from all over the globe on a trip down the road to revolutionize, discover, and live the glory of global surgery. With exciting surgical workshops like advances of robotics in global surgery, systematic reviews, review articles, and principles of clinical communication, engaging keynote sessions like AI in global surgery, women in surgery, innovation in neurosurgery, and publishing as a med student, an enlightening career pathway panel discussion, and research competitions. The last 3 days have been a true celebration of global surgery, and these enriching discussions have paved the path for the future of surgery. I would like to thank each one of you present here today for making our conference a huge success. We thank you for your enthusiasm, and the lovely feedback we've received from all of you makes all the effort worth it. I would now like to call upon Akatya Vidushi, founder and president of GSN, to say a few words.
Thank you, Smriti. Firstly, I would like to congratulate everyone on the OC of GSN because I know we've been working very hard for the past 1 week, and not just 1 week, but like months. But the last week was really tiring, and everyone was really on their feet and gathering all the Google forms and starting from scratch and everything. So it's really amazing to see the team working together. and we really made it worthwhile. All our efforts did show, and I am sure the delegates had a great time. All the keynote sessions and the workshops, everything was really, informative, and everybody did get to learn a lot of the things about global surgery, especially. Talking about the panel discussion was talking about USMLE, PLAB, and NEXT, which I think is really important for all of us to know that how the pathways are, and especially for medical students, so they can, pave their paths and know how and what to do for their own respective journeys, whether they want to go to the US, UK, or just stay in India and, succeed. So I think all the sessions which the team had planned was really worthwhile and did add to their professional development. And I think this 3-day conference was extremely exhilarating and a great experience. And I'm so proud of each and everyone for giving their best, and everybody did a great job. So yeah, thank you very much. Over to you, Smriti.
Thank you, Akatya. Before we end this closing ceremony, I would like to thank Rupali Sachdev for supervising all the events on day 2 and ensuring that all sessions run smoothly. Let me now introduce you all to the wonderful minds who have spent the last few months planning out every part of this conference meticulously. Presenting to you the organizing committee of the RGS 2021 conference. Scientific team, led by Tanvi, and the members were Kapil Raj, Dev, Ishan, and Arpit. The workshop teams, Advances in Robotic Surgery, had Smriti, Pooja, and Prastuti. Systematic Reviews team had Shraddha, Aditi, and Jay. The clinical communication team had Shrey, Ikshita, and Tarashi. Over to the keynote teams. Artificial Intelligence in Global Surgery had Smriti, Shamalan, and Roop. Innovation in Neurosurgery had Sneha and Pooja. How to Publish as a Med Student had Reena and Roop. Women in Surgery by Udit, Shamalan, and Ananya. The case discussion team had Priyati, Shubhro, Meghna, and Simran, and the panel discussion team had Zishan, Yashaswini, Mansi, Samiksha, Divya, Saloni, and Raza. A big shout out to this amazing OC without whom the RGS conference wouldn't have been possible. I would now like to invite Reena to thank the collaborating parties for giving us a wider platform and helping us reach medical students in different corners of the world. Over to you, Reena.
Hello, everyone. Am I audible? Okay, so moving on, one of our collaborators could not make it during the opening ceremony due to some time zone differences. So I'd like to call them the Surgical Society of International Doctors. Praveen, we can't hear you.
Can you hear me now?
Yeah.
Okay. Thanks, Reena. Apologies for not being able to make it on the initial session. But anyway, so I'm Praveen. I'm one of the Southeast region representatives of Surgical Society of International Doctors in the UK. And firstly, it gives me immense pleasure to talk amongst a wonderful group of medical students and graduates from all around the world. And I should mention that I can imagine the amount of efforts that GSN has put in to pull out this wonderful program, and it is really commendable. So a bit about Surgical Society of International Doctors. Just like how you guys are at this stage. I mean, I was a medical student in Chennai. I mean, I really wish I had known such a kind of societies that is being run in India, but unfortunately I didn't have much of an exposure. But anyway, having come to the UK, currently I'm a clinical fellow in neurosurgery in Brighton, doing my non-training mirror rotation. I would say it's like not a training program, but I became a part of Surgical Society of International Doctors since August, and we are a fairly new society. Basically, we are a group of 10 to 12 international medical graduates, just like me, who started as an SHO, but now a couple of our representatives and leads have entered the surgical training program successfully in the UK. So we aim at helping students from all over the world and medical graduates to connect and also to promote in terms of their portfolios and help them successfully enter surgical training program. Reason being that if you see the surgical training portfolios and stuff, this is more oriented to the local trainee graduates. Reason being, every university in UK, for example, Cambridge or Oxford, they've got a specified surgical society that supports them. So basically, you not only have to be a clinician, you should also be a holistic approach in terms of your portfolio. So you need to practice your leaderships, teaching experiences, and all those things are being fine-tuned with the help of those medical societies there in every region in the UK. So we wish to bridge that gap for the international medical graduates, and that's one of the main reasons why we brought up this society. So we've got a couple of projects going on at the moment, like a mentor-mentee initiative, wherein we help students and graduates. So every mentor has got like 1 or 2 mentees from India or from Egypt. So they continuously have monthly meetings or like a supervisor meetings that happens in UK for medical graduates, and then we help them clear their doubts and build their portfolios in terms of surgical application. And also we help them practice leaderships and teaching skills in terms of organizing programs and stuff. So that's what we do, and it's been like 6-7 months since we've started this project, and also since the start of our society. So finally, I'd like to thank Akatia, Vidyushi, and the entire GSN team for providing us with this amazing platform today, and help us reach and help a lot of medical students and graduates all over the world. Thank you.
Thank you so much, Pravin, for that introduction of the Surgical Society of International Doctors. I'd like to thank all the collaborators. The first one being AMSA Malaysia, ARU Society, Surgical Society, Women's Surgeons of Kuwait, Surgical Society of International Doctors, KCL Women in Surgery, Bridging the Gap Academy, IMA MSN Punjab, IMA MSN Karnataka, Squad Medical Research, Doctors for a Cause, Medicine, Make Medical Easy, and SNO Kriggs. Thank you so much for being a collaborator. It was lovely collaborating with you all, looking to work with you all in the future. Handing it over to Smriti.
Thank you, Reena. We've now reached the end of the closing ceremony. All delegates, please note that we will be sharing a feedback form at the end of the conference, and filling this form is compulsory to be eligible for receiving the RGS certificates. Once again, I would like to thank all of you for attending the RGS conference. We can't wait to see you all next year at RGS 2022. Stay tuned for many amazing opportunities coming your way at GSN. Thank you and have a great day.